We must demand that women's health is protected, funded, and prioritized because women's health matters to all of us.
We need people from all walks of life to stand up for women's health research because when we invest in women's health, the benefits ripple across families, communities, and generations.
When we design medicine for only half of the population, we fail everyone. But when we design it for everyone, we can transform the future of health.
This is not a niche topic. This is not a niche market. This is health in general. Women's health is everyone's health.
What our scientists are uncovering right now are things that medicine never knew before.
And women's health is really, it's really the gem to be uncovered in this time.
Let's share data. Let's be part of collaborative research platforms. Let's not move only at the speed of our own organization. Let's join these collective efforts.
The data is clear, the opportunity is massive, and the time to act is now. Good afternoon. I'm Carolee Lee, CEO and founder of WHAM, a nonprofit dedicated to accelerating research and investment in women's health. And I'm delighted to welcome you to what I believe is a truly critical conversation. We have mapped the human genome, and we're advancing in AI at an extraordinary pace. And yet we only captured the first detailed images of the female brain during pregnancy in 2024. That gives you some insight into how challenged we are in building knowledge of the female brain on such an incomplete foundation. And this year makes that disconnect even more clear, as longstanding guidance on hormone therapy is being reevaluated, including the recent removal of a broad black box warning on many hormone therapies. It's becoming increasingly evident that our understanding of women's biology and its impact on the brain has been really incomplete. And when it comes to women's brain health across pregnancy, sleep, and menopause, that reality becomes impossible to ignore. And despite everything we've learned about the brain, one critical dimension remains underexplained: how it changes in women over our lifespan, not because it's unknowable, but because for decades it hasn't been fully studied. So consider this: only 0.5% of more than 50,000 neuroimaging studies since 1995 have focused on health factors specific to women. And Emily will talk to us more about that. Women with sleep apnea are significantly more unlikely to go undiagnosed, and up to 80% of women experience neurological symptoms during menopause. This isn't a small oversight, it's a fundamental blind spot in how we understand the female brain. From pregnancy to menopause to aging, women's brains undergo profound biological changes, yet the science, the care models, and the investment strategies shaping brain health have not kept pace with that reality. Today's discussion starts from a simple premise. If we don't understand how the brain changes across the female lifespan, we're leaving scientific insight, clinical progress, and significant market opportunity on the table. So today we'll explore this across three critical stages: pregnancy, sleep as a through line, and menopause, to better understand where the science is advancing, where gaps remain, and where the greatest opportunities exist to translate insight into prevention, care, and innovation. This is not a niche issue. This is a frontier of science with a broad implication for how we understand disease, how we develop therapies, and how we invest in the future of women's health. At WHAM, we focus on one core idea. When you invest in the health of women, you unlock insights that benefit everyone, while also capturing one of the most significant growth opportunities in healthcare. Today's discussion is about where that opportunity is emerging most clearly, where the science is advancing, where the gaps remain, and what can be done across research and clinical development to accelerate progress towards 3-not-30, one of WHAM's goals. We're privileged to be joined by extraordinary leaders: Dr. Emily Jacobs, director of the Ann Bowers Women's Brain Health Initiative and professor of neuroscience at UCSB; Dr. Steve Goldstein, professor of obstetrics and gynecology at NYU Grossman School of Medicine and a gynecologist, and past president of the North American Menopause Society and the International Menopause Society. And Dr. Katie Sharkey, director of the Center for Sleep and Circadian Rhythms at Wake Forest University School of Medicine, Atrium Health Wake Forest Baptist. So thank you to all of you for being here, and let's begin. And with that said, I'd like to turn to Emily, whose work is helping redefine how we understand the brain across a woman's life. Her research has produced the first detailed map of the human brain during pregnancy, and an area that until very recently had been largely overlooked in neuroscience. So Emily, I wonder if you could please share with us a little bit about your work and how you've watched and seen the brain change during pregnancy, and why has neuroscience historically overlooked this transition?
Yeah, happy to jump in. And first, I'd be remiss not to start with just a huge thanks. Carolee Lee, what you're doing here at WHAM and the entire WHAM community is transformative in having these kinds of conversations, changing the tenor of the conversation. So just ever so grateful to be in your presence and having this. So I think as a neuroscientist by training, I'm always driven by the data or the lack thereof. And for me, this aha moment of thinking about women's brain health came when we put real numbers on a kind of quiet convention to say, as human brain imagers, we rely often on magnetic resonance imaging, MRI, as a tool to peer inside the brain to understand how it works when it's healthy, or what goes wrong when it's not. And we've had this piece of technology. I think the first images of the human brain were produced in the late 1970s. So we have some pretty good historical data to say, what have we done in the last 50 years? As you mentioned, we published over 50,000 articles on the human brain, but of those, less than half of 1% tackle female-specific health experiences, right? That's everything we know about how the brain changes across pregnancy and menopause in response to preeclampsia, gestational diabetes, menstrual migraines. The list goes on ad nauseum. So we are sort of at inch one of the marathon here. My lab specializes in something called precision imaging. So this idea that we can map the brain over these really sort of highly dynamic temporal periods. A couple years ago, a brilliant graduate student, Laura Pritchett, developed sort of a map of the brain across the menstrual cycle. And we realized, so with images acquired every 24 hours, and we could, see that these were really dynamic periods. So when you have endocrine changes, that's driving brain plasticity. We know this from animal models, folks like Catherine Woolley, who've showed us evidence of synaptic plasticity at the subcellular level. Well, we can see that now using kind of more modern human brain imaging techniques. But if we can see those changes happening across the menstrual cycle, which is, this sort of rhythmic, coordinated ebb and flow of hormones, what's happening during pregnancy where there's an order of magnitude change in endocrine function. And so that's what led us to do a precision imaging study mapping the brain across pregnancy. Suffice it to say, these neuroanatomical changes are profound. They really sort of are in magnitude to the changes that we see during adolescence, right? Another developmental window where hormones sort of flood the system. There's sort of two core processes that really shape, we know, the adolescent brain. It's marked by synaptic pruning and myelination. And we're seeing the exact same thing happen in the maternal brain, which means, right, the adult human brain is capable of levels of neuroplasticity that neuroscientists more or less thought was done, by age 12, 13. And we can do that now using modern brain imaging methods and techniques. We can see this unfold week by week over the gestational window.
Well, your work is groundbreaking, and we are so appreciative of all of the energy, focus, and commitment that you've made to it. I was thrilled to be able to participate at your conference last month out at UCSB, and just blown away by what you've created. Maybe our team could put your short video in the chat, because I think it's worth seeing a video that the Bauer Center and Emily made that's quite extraordinary. I'll come back to that, but Steve, I'd love to turn to you. You are, as we know, a highly recognized leader in menopause care, and you've spent decades working directly with women to better understand and help them manage the physiological and emotional changes of perimenopause and menopause, including the role which you and I have talked about a lot, which we're not going to be able to get into in great detail today, of hormone therapy. So why is menopause such a pivotal turning point for brain health? And what are we still missing clinically? And what fascinates you?
Well, I also want to thank you so much for everything you've done and all the time that I've known you in WHAM and even, this seminar today. I cannot sing your praises enough. And Emily did a very nice job of it. So it's an example of what she said. Um, but understand that I'm an educator and I'm a clinician. So I'm the one who's taking what science we know or hope we know and trying to translate that into the care of patients who are sitting opposite the consult room table from me. And I think even the wording of your question underscores some of the problem as I see it. When I speak to a lay audience, I often use the title perimenopause, menopause, postmenopause. Why is it all so confusing? Menopause is when there is no more ovarian function. So you are menopausal and you are postmenopausal, and you are going to be that until you die. Perimenopause is the transition from the reproductive years to the non-reproductive years. In fact, in many aspects, it's the mirror image of adolescence. But it's this umbrella phrase that I think is problematic. And I'm going to take a moment because I want your audience to understand this. The earlier stage of perimenopause is really characterized by very chaotic, often increased levels of production of estradiol, estrogen from the ovary. There's usually a lack of ovulation and therefore no progesterone is produced. There's often very irregular bleeding and menstrual flow, as well as all kinds of symptoms such as brain fog, which is clearly the topic for today, but increased anxiety, fatigue, sleep changes, mood swings, inability to concentrate. And one thing that has been shown in that perimenopausal transition is there is a decrease in verbal memory and verbal learning. The good news is most of that is transitory. The treatment is suppression of this chaotic, erratic ovarian function and substitution of a stable amount of hormone all month long. Later, so it's not replacement. Later in perimenopause, although it still has that nomenclature, estrogen is very low or absent. If they get hot flashes, they tend to be much more consistent. And now replacement of hormones may well be appropriate. But both of those stages are called perimenopause. And I think this is confusing to patients. And unfortunately, in my opinion, this has been confusing to many, if not most, of the practitioners who are new to the field.
Yeah, I could go on and ask you so many more questions, Steve, but I'm gonna pass it on now to Katie Sharkey, and then we'll come back.
Okay.
And thank you for that. Yeah, and thank you for sharing your thoughts on the different stages, because we need to understand that much better. Katie, your work focuses on one of the most powerful and yet often under-recognized drivers of brain health and health, sleep, something that we all crave much more of. And I know that your research examines how sleep and circadian rhythms influence women's mental and neurological health, and particularly during periods of hormonal transition, such as pregnancy and obviously postpartum. Why, and I don't know how you're going to be able to do this, why is sleep such a critical but such an overlooked driver of brain health across every hormonal transition in a woman's life? And no, you don't have an hour, so I apologize, but trying to share as much as we can in such a short period of time. Thanks, Katie.
Sure. So I'll very briefly add my thanks, and I'm really honored to be part of this conversation and very glad to sort of represent the sleep world as part of this conversation, because I think that historically people have thought about sleep as, okay, I'm turning my brain off at night. Okay, I'm going to turn it back on in the morning. And indeed, we know that sleep is not a passive, brain is just recovering state. There's many active processes that are going on neurologically during sleep, including some hormone manufacture and secretion and some of the feedback loops that drive our hormones are affected by both sleep and circadian rhythms. the brain's doing critical work during sleep, like at multiple levels, at the physiological level and also at the emotional regulation level. And so when it's disrupted, I'm not just a sleep doctor, but I'm awake doctor too, right? Because it is feeding forward. And I would say that, that two of the things that I think make sleep so salient here, one is that we underappreciate how much how we feel today is not just affected by last night's sleep, but really about our habits and patterns over a long period of time. And hopefully that makes sense to people, that if, given the sense that sleep sometimes feels fragile, that it would be pretty crummy system if one bad night here and there kind of derailed us for the long term, right? So, which leads me to my second point, which is sleep is modifiable, right? So at some level, the menstrual cycle is going to be the menstrual cycle, and those hormones are going to get secreted and go up and down over time. A pregnancy those hormones are going to change. And so the challenge for people in the sleep world is to say, well, how can we preserve sleep in these settings? I love, Steve, what you said about that perimenopausal time is kind of a stabilized, the havoc isn't so much the decrease as it is everything's irregular. And so everything's not catching up to the other thing. And which has feed forward mechanisms. So the fact that sleep is an active process is important. The fact that we can intervene on it, and that we probably need to intervene on it differently at different life stages, is important. And the fact that it's bidirectional. So some of the things that we experience, whether it's day in, day out at a reproductive transition or a specifically hormone important time, or whether it's day in and day out, that's affecting sleep and being affected by sleep. So I'll leave it there for now.
Yeah, thanks, Katie. I mean, again, a million questions, but let's keep going. We'll come back. So Emily, let me just come back to you. Are the brain changes during pregnancy temporary adaptations, or do they fundamentally reshape the brain for the long term? And then if so, what does that mean for women's cognitive health later in life? So is my brain changed forever, having had 3 kids each time? And God, I can't even imagine what it's like right now.
A little bit of both is what the sort of current science tells us. So we can actually, and Anne-Marie Delange has done this with UK Biobank data. So folks who are mainly in their midlife 50s and 60s, and from a single snapshot, single MRI using machine learning, she can actually predict parity status, and not just parity status, but the number of kids from a single MRI image taken in your 50s and 60s, which is to say that we think that the sort of brain changes that are being laid down during matrescence are sort of permanent etchings in the brain, right? These are sort of permanent remodeling, more or less. But what we're seeing with this sort of precision technique, where we can actually follow women, not just before and after pregnancy, or not even decades later, but during pregnancy itself for the first time, there's actually a whole kind of orchestra of changes that are going on with sort of, heterochronous trajectories, so different temporal trajectories, some of which are like the brain's cerebral vasculature system, which we can access via arterial spin labeling. That's undergoing really dynamic changes during pregnancy, but if you scan somebody just before and after, you miss all of that, dynamic change. Changes like the gray matter volume, where we see about a 4% reduction in gray matter volume, those seem to be fairly permanent. A little bit of sort of rebound, but fairly permanent. And we think that that's probably a feature of the system, not a bug of the system.
So then explain to us how then research and clinical studies should evolve, in your opinion, and capture in a better way what these transitions are, especially considering the long-term risk for things like Alzheimer's and other dementias.
Yeah, I mean, what's promised, what we know is that these sort of adaptations that are being laid down during pregnancy can tell us about brain health long term. We know that pregnancies that happen later in a woman's life might have kind of knock-on advantageous effects. We don't know the mechanisms behind that, but we know that it tends to be tied to sort of protective effects. Again, all of this sort of asterisked by the fact that this science is so new and emerging, but pulling together what we think so far. When I think about the kind of clinical needs, I'd say the two big low-hanging fruits here are thinking about things like perinatal depression. That should be a tractable problem, right? We have this 40-week gestational window in which, 1 in 5, 1 in 6 women will experience this event. That is actually a sort of perfect experimental paradigm to understand the sort of emergence of something like a perinatal mood disorder. We think that we can do that with really detailed both brain imaging, sort of advancements in high throughput proteomics to look at sort of signatures that might be changing even before these behavioral manifestations. Because, 2023 marked the year when we had, I think, one of the first medications available for perinatal depression. But of course, we need to be able to diagnose early to match people with the treatment that they need. So early diagnostics is going to be important, and I think we can make headway in that space in the coming years. The other question I think that's really interesting is we see at a population level this link between hypertensive disorders of pregnancy, things like preeclampsia, and that increased risk of vascular dementia 30 years later.
Right.
What is that all about? I think, again, with sort of advanced imaging techniques where we can map the brain's cerebrovasculature system, get a really good understanding of how pregnancy, which obviously involves this overhaul of the cardiovascular system, including the cerebrovasculature system, how can we understand those links? Such low-hanging fruit with such potential impact to transform women's health.
Yeah, thanks for that. There seems to be a lot of movement around, a lot more information, a lot more research on preeclampsia and the long-term effect. Steve, let me come back to you and talk a little bit about the recent attention on the updates to the hormone therapy guidance, including the changes, which I know everyone is talking about on black box warning. So how, and I know you have very strong opinions on this, how should clinicians and patients interpret this moment? And what does it mean for brain health? Because brain fog is real, and the decision-making around HRT.
So understand the removal of the black box warning in November is sort of that good news, bad news story. The good news was it was long overdue. I mean, the existence of that boxed warning resulted in thousands, if not millions, of women who could and should have taken hormones not doing it. Many practitioners refusing to prescribe it. Many medical students and residents who were never taught this because it was let go of. So removing that scary black box was essential. The way it was rolled out by Commissioner McCary was a travesty. The press release and the hoopla that came along with it, he claimed that hormone therapy could reduce cardiovascular disease 50%, and he gave in that press release a single reference from Elizabeth Barrett Connor in 1992, a summary of some old, terrible observational studies. He claimed it could reduce Alzheimer's disease 35%, and he gave one reference from a cohort study in a retirement community in Southern California in 1996. Yet, his rollout was widely publicized, which actually is a great segue into this concept of where are the gaps currently. And I think the gaps, in my opinion, as an educator and a clinician, are in education and misinformation. And you can blame a lot of that on McCary and on social media. When I was president of the Menopause Society, for years, there were roughly 2,000 members. Last year, the membership exceeded 12,000 practitioners. If I was at a cocktail party talking to some women and told them I was a gynecologist and I mentioned I was president of the Menopause Society, it cleared the room. It was a dirty word. It was associated with old and wrinkled. Now, it's not having a moment, it's a revolution. And it's a good thing that it's been brought out of the closet. But as most things, I think the pendulum often overshoots the mark. I mean, there's such a lack of available qualified practitioners that people are turning to all kinds of online resources. You realize MediaHealth.com has been valued at $1 billion. You get a telehealth visit and you get hormones mailed to you on the mail. Nobody examines you. I mean, the people in the field are extremely concerned. And this frenzy about hormone replacement, for many, many women, this is going to be the right answer. For many women, it is not the right answer. Understand, other higher order primates, they live a year or two if they stop reproducing. My patients are going to spend 40% of their lives in a post-reproductive state. I mean, it would be wonderful to have longitudinal, long-term studies where we could use preparations of hormones that, let's say, mimic the premenopausal state and see what the effects are. And you can't really speed that up. If you're really looking at brain health and hormones, you're not going to have your answer in 6 months or a year or 2 or 3. You really have to follow people longitudinally. And because this is all about not living longer, it's living better. And so I see that as one of the gaps.
So, Steve, just to stay on that for a moment, then I take it you're not very fond of us experimenting with different types of hormone therapies that I can buy online. Is that an accurate statement?
Well, in the sense that I don't think it's thorough enough. In other words, I've heard too many stories. You can be 35 and get online with some of these telehealth situations, and almost regardless of what your complaint is, you will be mailed a prescription for an estradiol patch and progesterone. And I mean, I've heard, and nobody examines you. And then if you bleed 3 months later, your doctor sends you for a sonogram. Nobody examines you. It's a travesty. I had a patient like this, and she had a big polyp coming out of her cervix. Nobody had examined her. I'm apoplectic.
Okay, that's what I thought. I just wanted you to say it. Thanks. So, Katie, what happens to the brain when sleep is chronically disrupted during these key hormonal transitions like pregnancy? And by the way, mine is disrupted, and I'm definitely not pregnant. So, what's going on?
Well, I will say that when I care for midlife women, so I practice sleep medicine, and when I care for midlife women, they often say to me, "Yeah, I haven't slept well since I had my baby," and their baby's an adult. So it does. So I resonate with what Emily said about it can start there and then be a harbinger for what happens in the future, and we really learn a lot about that. I'll start with deep sleep, right? So the beginning of our night is deep sleep. We think this is the most restorative sleep for a lot of different reasons. If you deprive someone of that deep sleep, they make it up preferentially the next night, right? So that sort of speaks to the biological need and imperative there. And, now that we've started to unravel what's happening during that deep sleep. So this is when, people have probably heard of the glymphatic system in the brain where, it's clearing out different metabolic waste from the brain, including amyloid beta and other things that make us at risk for Alzheimer's disease. So, if that slow wave deep sleep that we're getting at the beginning of the night is fragmented, is that potentially impairing that clear out time of the brain during sleep? Absolutely. We think that is the case. How far back does that go? Again, not known. When I would say it's never too early to start aging well, right? And and I think that that's why a lot of times clinically, I'll be trying to get people to have good patterns. I mentioned before, having one bad night, it would be a bad system. But the more that we can lay down, good habits, the easier it is to slide back into the right groove. So during pregnancy, again, this is a known thing that you're going to get up and have to take care of an infant. And so, I would contend that there's some data suggesting that the brain is compensating, I think is the right word I want to use for that during pregnancy. So, prolactin, which we make to lactate, females make to lactate with prolactin. Prolactin is manufactured preferentially during this slow wave sleep, and exogenous prolactin, so which you wouldn't really necessarily give, but that we know from cases where someone has a pituitary adenoma that makes prolactin, that increases the slow wave sleep. So that's nice evolutionary adaptation, right? That if you're in a state of postpartum, you're making a hormone that not only helps you feed your infant, but also increases the depth and the amount of the sleep that we think that you need, that we think is most restorative. So, that's one example. Another example, there's a sleep disorder called restless leg syndrome, where we know that is tightly linked to iron deficiency in the brain. And so you're not anemic from, you can have low iron storage. And again, one of the 3 not 30s, Carol, is that we now know for restless leg syndrome, the ferritin level that we think we need to have people at is 75 nanograms per ml. That is in the middle of the normal range. So right now on labs around the country, if you get this level checked, which you probably would not have checked unless you were anemic or unless you saw someone who knows about iron in the brain, the lab would come back normal, because the lab norms are, I don't know, 12 to 300 different by different labs, but 75 is way above like the low point, because that low point is set for how low does it have to be anemic. So, and again, we're just now figuring that out. The other thing is, we know that pregnancy is a state of relative, and you're giving blood to this other person that you're growing inside your body through the new organ that your body manufactured just for pregnancy. And there's a additive effect where second pregnancy, if you were low ferritin and had restless legs during first pregnancy, it's going to be worse second pregnancy for every iteration feeding forward to when you are older. So that's just like one example. And then the perimenopause part, right? Like some of this too is that then because of cognitive impairment that comes from sleep fragmentation and memory difficulties and things like that, those affect then our behaviors and our decision making. And so to the degree that we're all a sum of our good and bad choices that we make every day, right? Like we want to be running optimal. We want our brains to be working as well as they can, with making diet and exercise choices, saying, yes, I am going to go take that walk because I need to move my body every day. So again, I'll stop there, but I think that there are profound effects. I think they affect not only these hormonal inflection points, but all of our whole lifespan.
Yeah, that's so true. Steve, brain fog is generally dismissed or often it's in your head, which of course it is.
Yeah, the brain's there.
But talk to us a little bit about brain fog.
No, I think brain fog is a very real thing, much more so in this menopausal transition rather than when people are truly menopausal. When they finally become menopausal, this often improves some. And the main part, there was a thing called the Women Living Better Survey. They surveyed 2,500 perimenopausal women going through the menopausal transition and came up with this very popular thing in our world called NFLM, not feeling like myself. And one of the main complaints was, in fact, brain fog. But the same group also said it is very challenging to sometimes disentangle the rest of life that occurs, in addition to the hormones. And that's why I love what Katie said about sleep. In other words, sleep, mood, anxiety, hot flashes, hormone levels, all feed together into this. And it is not simply one of these things. If you look at a Venn diagram, these things all overlap each other. And it can be very challenging to disentangle. And it was really, really helpful that this group that published this first article about not feeling like myself came back with a second article saying, it's not always just hormonal. I mean, it's the sandwich generation. Many of my patients, they've got kids who are growing up. They've got elderly parents. Look at the world we live in. Look at the stressors. I can tell you that the single I know we're interested in brain fog, but the single most disquieting symptom that I have heard over the decades that I've done this is the sleep disturbances. If you don't sleep on a chronic basis, you are toast the next day. Hot flashes are annoying and they can stop you in your tracks, but sleep is just, I cannot stress it enough. And I loved what you said about iron. I mean, we just ran a course at the Westin this past weekend for 200 practitioners, another 100 online. And we talked a lot about iron deficiency way before you become anemic, not only restless leg, but fatigue. And people need to have their iron levels checked. It's not enough to just say you're not anemic. And more of us who are in the front lines are realizing that and trying to get that word out. But I appreciate your comments.
And just to jump in there, if we want to take the iron thread, because, I think you can think about heavy menstrual bleeding early in menarche as a result of endo or PCOS. And it used to be that this was just sort of an annoyance of the reproductive tract. But the more neuroscientists realize is when you're losing massive amounts of blood, you're losing massive amounts of iron. Iron is a critical precursor to dopamine production in the brain. Dopamine plays a critical role in executive functions like working memory. And so what you end up seeing are kids masking as if they have ADHD-like symptoms when, just give them some ferrous sequels. And so having sex-based targets of what iron levels are appropriate, because you start to see this convergence, this sort of sex difference in basic iron, and the incipient event is menarche in girls. And I think it's that through line where we see in pregnancy and in menopause as well.
Who sets those ranges?
Not the three people on this call. But Carolee, like, this is truly, it really is a policy problem, and it's an education problem. I love what Steve said about, I'm the generation that we did not learn how to prescribe hormone replacement. And now it's too bad I'm at a different conference this weekend. I would have loved to have gone to, I feel like that's now something that is on my professional goals for the next year, is to educate I'm an internist and a psychiatrist by training. I don't imagine that I'm not trying to imply that in a weekend, I'm going to learn everything I need to be able to prescribe HRT to people. On the other hand, you should have me learn, because I know enough of the other stuff that I don't think I'm not starting from first year of medical school where I don't know anything. Right. So I think we need but I think this is a workforce issue, right? Is how do we get people, it's same with insomnia, we have this with insomnia, right? There are great treatments for insomnia, behavioral treatments. We do not have, there's 430 something people boarded in this around the country, right? So as I'm at a sleep conference. So somebody told me yesterday, the ratio is 11,000 to 1. I laugh because if I laugh, I'd cry. Right. And so,
now do the same thing for reproductive psychiatry.
Right.
How many of those are there in the country? I think, Katie, I think your point is so right. We need continuing medical education, which means often using the levers of sort of policy. We tried to do this in California with the Menopause Care Equity Act, and we couldn't get it over the finish line in California. So imagine the headwinds, they're strong. I'll give another example.
But I'm sorry, go ahead.
No, please.
I was just going to say, this is where people in our world learn from people like Carolee, right? Because there is an economic, right? Like, if it's a money problem, which Carolee, I learned so much from you, and I'm not saying that's your only focus, but about finances, and how to make people make the economic case for why this is why it's bad, right? If we have treatments, everybody wants to defend their practice turf and whatever. And I say to myself, when was the last time you were not busy enough? Right. Does that, and so, I think that with the right training, we are going to have nurse practitioners who are, and PAs, and there are folks that are, if they're interested in this, we have to expand the workforce to be able to take care of these folks. And I actually think perinatal mental health is actually a leader and a great example of, there's everybody from community health workers who are trained to identify, okay, this person's in trouble, right, and sort of build the, we're collapsing under our structures right now because we've not developed a workforce that can triage who needs what. And I know that's probably a radical thing to say, but also we can't just offer these treatments to the people who live right next to a place that has a perinatal mental health expert, right? Because somebody's living in a place where they're 2 hours from a hospital. So,
yeah, for
So
sure.
I need to jump back in for a second because I want to
go
bring
ahead,
us back to the menopausal hormone therapy.
Yeah.
Because there's too much misinformation out there. So we got to start with the idea menopausal hormone therapy is not to be used simply to prevent cognitive decline.
Agree.
And regardless of what people are out there saying. And I mean, sometimes people talk about the Women's Health Initiative memory study. There was women over 65 who had an increase in probable dementia, whether they took the estrogen by itself or estrogen with a progestogen, and people complained it was the wrong formulation. But I mean, you can look at so many large observational studies in Finland, 84,000 women, the UK, 115,000 women, Taiwan, 105,000 women, Denmark, 61,000 women. Granted, they're observational. None of them show a benefit to preventing cognitive decline with the use of hormone replacement therapy. And people often say, well, they didn't use the right formulations, but in KEEPS and ELITE, we were using formulations closer to what people are using today. Although it was short term, you did not see support of that. So I think the question does come up as a clinician, what am I telling people who are concerned about cognitive decline? And I mean, I learned enough from people like Pauline Mackey, the bottom line is, and they finish every lecture by saying this, that brain health is heart health.
Yes.
If you're interested in having a healthy brain, what's your blood pressure? What's your cholesterol? Are you pre-diabetic? Are you socially engaged? Are you exercising? What's your diet like? Are you not smoking? Are you moderating your alcohol intake? Are you learning some new skill to increase cognitive reserve? Learn a new language, take on a new function, stay socially engaged. These are the best ways to protect yourself against cognitive decline. But going on hormone therapy simply for that purpose, is not the answer, regardless of what Commissioner McCarry tried to tell the public.
So Emily, what is the answer?
I think the answer is better data. I think we are all trying to do the best we can with historical data sets that were not designed to answer the questions that we want them to, which is why women go to their doctor and are confronted with a medical system that was not designed to serve them. And that's been true for 300 years, forever.
Yeah, well, since we've been around, since this group of women. So, Katie, if that's the case, and obviously there are different sleep patterns for women because of the different phases that women go through in their lives. What happens as we get a little bit older and sleep becomes even that much more difficult?
Right. So I think, I also want to agree with what the other two folks said, right? Because I think that, we do need more information. I also think about bone health. So I would put that into that category, right? Like, and it's, we're talking about multifactorial health problems where it's like, which switches do we have control over and which ones don't we? And again, I think that's sort of where the sweet spot is, both with sleep and with getting, like, updating our guidelines around the iron levels, right? Trying to say, okay, we know more, now we have to do more. So you asked me about sleep and aging. So, we know that sleep does change, but, many people sleep ages very well, right? I mean, there's definitely, it's not a foregone conclusion. And I do think that is probably the first entry point where I would start with sleep, is that many people think that, oh, this is normal aging, that I'm not going to be sleeping. And so then they don't even, the data are that 80 something percent of people don't even tell their doctor they're not sleeping during menopause or as they grow older, and they just think that that's their lot in life. And, there are certainly medications that we know have sort of narrow therapeutic indices in aging, but there's also new medications being developed for treating sleep. And, in some ways we have to demand that we're not going to just take meds that might lead to more dependence and tolerance and those kinds of things, and push that, that preserving sleep is important. And there are, the other thing is really encouraging people. So again, with my sleep doctor hat on, encouraging people that there are behavioral things that work, right? I'm struck, Steve, by you saying what people can Google and then find out. I'll have patients come and go, well, I've tried sleep hygiene, and they're mad at me. I'm like, okay, don't be mad, because they've read about something, but that's not the same as this behavioral treatment. The main one that we have is cognitive behavioral therapy for insomnia, which is a very structured, prescriptive, personalized, before even personalized medicine was hot, scheduling to kind of glue sleep back together a little bit. There's also brief behavioral therapy. There are FDA approved and clinically trialed, tested virtual versions of this for my made up patient that's 2 hours away from a practitioner, right? So, we have tools that we're not even using. And as people age, it does, again, Steve, exactly what you said, you have to have social relationships, you have to, and so who wants to do that if you didn't sleep well? And you're so tired. The things that you need to do to have good heart health, the things that you need to do to socialize, or I'm going to learn a new language now that you suggested it, right? Or get back to the guitar or whatever, right? Like those are but if you don't have the energy to do it, or if you have mood regulation issues, which we, for many years, we were told, oh, that person's sleep will get better after we treat her depression, or but we really need to be treating sleep as its own problem.
Yeah, I totally agree. I'm sure everyone does, and it's a big problem, although we're learning, I think, so much more about it, and especially with your insights and help, really appreciate it. Emily, what are you the most excited about that you're working on right now at the center?
Going back to sort of my plea of what we need, which is, I think, better data. That's really sort of what the Women's Brain Health Initiative is all about. We have 4 big projects that have launched. One is the WBHI Brain Bank, so building the largest and most comprehensive collection of brain imaging data ever acquired for women's brain health. We can do this at the University of California because we're 10 campuses spread out across this beautifully, geographic and demographically diverse state. So we are pooling data collected across our 10 campuses into a central repository. We're pairing MRI data with the neglected women's health variables and amassing what we call sort of our data discovery, our incubator. Because one of the problems in neuroscience is there's so much we don't know that knowing where to begin can be the hard part. So that's happening. We've launched our longitudinal menopause project to track women deeply over time for 10 plus or more years. And I love this discussion because our MO is that we have reproductive psychiatrist, immunologist, neuroscientist, sleep med doctors, AI folks all coming together to learn as much as possible about this period of time, deeply, heterogeneous types of data, because the brain does not age in isolation. It is doing it in packaged in a body that's packaged in a world. And so I think we have to take all of that into account to truly understand normative trajectories of brain chart changes, and neuroscientists have built these beautiful brain charts across the lifespan. What are we missing? Like the sort of critical events in a sort of women's life. So we're creating brain charts across pregnancy, across menopause, and then understanding what might deviations from those norms mean and look like. And just to polish it off, we've launched the Global Maternal Brain Project. This is an international effort to, again, understand those trajectories and how they might diverge in women and why. What are the social factors? What are the sort of biological factors that can tell us about brain health? And then maybe my final note for this audience is we lack standardized ways of assessing women's reproductive health. This is some place where STRAW, the Stages of Reproductive Aging workshop, really made sort of a first step towards just trying to get everybody in the menopause space to like have an operationalized definition that's the same thing. That was a wonderful effort. Stephen, I'm sure you were part of. I know Pauline. Just so many luminaries in this field. We need to do the same thing with a lifespan perspective. So we're launching what's called the Standard, which is a standardized assessment of reproductive health across the lifespan. We'd love to see this adopted globally, because what we need to drive discovery, all sorts of types of data, from precision, but also big data. We know that the power of big data for genomics, particle physics, launched major discoveries for those fields. We can do the same for women's brain health, but in order to harmonize across data sets, we need data standards. And so we're working on that.
Well, it sounds like you don't sleep with all that you're doing. And we're very appreciative, obviously, of everything. So congratulations on all that you've been able to implement, initiate, and in which you're involved. Steve,
it's funny that she mentioned STRAW, though. I got to jump in here because
yeah, no, I was going to ask.
The study of women across the nation from SWAN and STRAW plus 10, and they've got this wonderful diagram that everybody shows at their meetings, and I think it's problematic because I think it's much too arbitrary. It tries to put people into these buckets, and it says on their thing, and I when I lecture on this, I show that diagram again with a big red circle around the two words variable. Because to me, there is so much individual variation. I made some new slides for this course this past weekend. The three most important aspects of caring for perimenopausal and menopausal women are: number one, individualize; number two, individualize; number three, individualize. Because there is so much variation from person to person that one person's experience, and one of the beauties of being a male gynecologist, I will never have a menstrual cramp. I will never have a labor pain. I will never have a hot flash. My experience is 35 years of listening to intelligent, articulate people educate me, and I've seen it go from A to Z. So I believe it all. I have no bias, even subliminally, to put onto my patients. And there's so much variability in people's experiences. That's why social media can be so dangerous, because people are constantly thinking that their experience can be extrapolated to the rest of the world, and it really can't. Anyway,
so
sorry.
one last quick, yeah, no, it can't. But Steve, if you had a magic wand and you were able to change anything or do anything with it, what would it be?
It's the education process. It's really the education process. I mean, that's what I do, and that's what I see is lacking. And I see there's a lot of confusion. There's confusion among patients. There's confusion among practitioners. And unfortunately, it's what Jen Gunter calls the menopause gold rush. There's everybody's selling something, and it's depressing. For those of us who've been doing this for decades and decades, and I'm not selling my own brand of supplement, I'm not selling subscriptions, just trying to give out some good information.
Thank you for doing that. Katie, rapid fire. You had a magic wand, what would it be? What could you do?
So things I'm excited about and the things that I think are going to be upcoming. I'm excited that people have all these wearables and that we're collecting massive amounts of data, because, that's another thing that has plagued this line of research is it's been in a lot of wealthy, white, married, highly educated women, and not necessarily a cross section of the communities that we aim to serve. So I think that's going to be democratizing. At the same time, I feel Steve's pain of like, now it's unleashed, and because for everybody that tracks and it helps them, there's someone that wakes up every day and looks at their app and it decides whether they're going to have a good day or a bad day by what the app said their sleep was like the night before, right? So I think there's a tension between how we use the medicate, this new information and this the data that we're able to collect. I agree, education is important, and just literacy about what sleep health looks like, the kind of common mistakes people make when trying to address sleep. I think it's Sleep Apnea Awareness Week this week. And again, I think that's someplace, especially with aging, I want to get the words obstructive sleep apnea. Women can have it. It's not just an old, a disease for older, heavy men, but people can have this for a variety of reasons. And now we have more of a plethora of treatments. So the magic wand, I would say, is people, continuing to think about sleep as something that's modifiable and that we can treat, and then doing our jobs to make a workforce that's ready to see those patients and address the concerns that they have early, so that we can get the aging process to go well with no heart attacks and hip break stuff.
Thank you, Katie. Emily, one last word, if you had a wish.
Education and awareness. We need to train the next generation of leaders in this space, and we need doctors and physicians to have, continuing medical education, so they are not, anytime there is fear in a space, and that is what maybe plagues a lot of the situation. You have people coming in to try to monetize, what Stephen said. So we have to do our part as scientists and clinicians to cut through that noise. So maybe that's PSA campaigns. I know Kat Bohannon's on this call. That's like providing factual, evidence-based information to the masses that cut through the noise. But also, as a sort of professor and a mentor, we have got to make sure that the next generation of thought leaders in this space are nurtured.
Yeah, thank you for that, those final words. And let me say my deepest thanks to all of you, because you're all exceptional, and your insights and leadership in your fields have been extraordinary. So thank you so much for all of you for joining us for this timely and important conversation. Hope you enjoyed it and learned as much as I did from it, which we always do. And I also want to recognize our partners and collaborators whose support make this work possible. But following today's discussion, we'll share a recording with all of the registrants, and we also hope that you'll join us for our next dialogue on May 19th, which will be a focus on cancer, rising risk, missed signals, and the path forward. Thank you for being part of the effort to accelerate research, investment, and innovation in women's health, and of course for supporting WHAM. WHAM needs this kind of dialogue to move us forward, because meaningful change doesn't happen by chance, it happens by choice. When people come together to shape what comes next, and that's what we're trying to do. So thank you for being with us today, and we look forward to seeing you again very soon.